Hi everyone. I am Ashma and I'm thrilled to welcome you to this live session hosted by Alliance India. Before we delve into our insightful discussion with Rajiv sir, let's take a moment to recognize the significance of this year's G20 being hosted right here in India. It's a remarkable opportunity for our nation to set the stage for global discussion on pressing matters, and one of the key priorities being emphasized is ensuring health for all. In a world that's more connected than ever, the importance of accessible and equitable healthcare cannot be overstated. This aligns perfectly with the theme of today's session, which is healthcare accessibility for all. Through this session, our aim is to uncover the challenges and opportunities within India's healthcare landscape, particularly for marginalized communities and key demographics. Joining us today, Mr. Rajiv Dua, Chief Executive of Alliance India, who brings a wealth of expertise to the table with years of dedicated work in the field. He has been instrumental in addressing the needs of key population and marginalized communities. Welcome, sir.
Thank you, Ashima.
So, your experience in working closely with marginalized communities and key population is invaluable. Could you shed light on the specific challenges these groups face, especially while accessing healthcare services in India?
So, let's kind of look at who are the most marginalized communities, right? As far as healthcare is concerned. So it's basically the poor people, okay? It's women and girls, okay? And then there are people who are stigmatized because of their behavior, okay? So it could be drug users, okay? It could be sex workers, it could be gay men and men who have sex with men, it could be transgender people and prisoners. Okay, so we forget prisoners, because just because somebody is incarcerated in somewhere, either in a juvenile home or in a prison or in women's home, something for a minor crime they would have committed or they're under trial. So they are also deprived of healthcare to a great extent. So I think these are the populations which largely, I mean, and there could be some specifics as well in different parts of the country which require access to health. So equitable access. So one is that access health should be available to all. Yes, that's the. Unfortunately, it is not a fundamental right in our constitution, but life is a fundamental right. So we have right to live, correct, and right to life. So if there is right to life, and you cannot have right to life without access to health. So health becomes a key factor for everybody. And what happens is that the segment of population, either due to economics or due to marginalization because of social stigma, are unable to access healthcare. So either they are denied access to healthcare, or they are kind of stigmatized, so they don't want to visit. So to give you an example of just two examples, like prisoners, they're incarcerated, correct? So they don't have access to healthcare unless the state provides it. And by the state, I mean the government, correct? So the state provides it. So, and the state then has to have, and the system of accessing healthcare for an incarcerated person in India or anywhere in the world is quite complicated. So either you should have a doctor in the prison, and they are mostly available in central prisons. But if you go down to sub jails and other facilities, the doctors are not present all the time, they visit. So if you have an emergency, then the whole process of securing a transport, taking them to the healthcare facility, getting them the healthcare is a big challenge. So similarly, let's take the other part of it. For example, drug users. So on one hand, as per the International Classification of Diseases, we consider drug use as a mental health issue. Okay, so it is a psychiatric disease or illness, if you want to call it, and has to be treated accordingly. On the other hand, we criminalize them as well. So when you criminalize a population which is mentally not fit, which means is that we are basically criminalizing an illness. And that is not neither fair nor just for a population to be able to access healthcare. So this is the challenges, and we can go on. But I would you can ask me questions before I keep on saying anything.
Yeah. So I think yes, you're right, and Alliance India is working towards these things, and I would like to know that how Alliance India's efforts are fostering to improve these healthcare access for these groups.
So overall, I think it's responsibility of all the organizations working in the field of health to ensure that they promote uh, equitable access to healthcare. Hmm. So it is irrespective of the person's social status, uh, economic status, the person should be able to have access to health. Now let's look at a little bit of background. What are we talking about? Okay. So generally, we say in a population that in a country should spend at least 3% of its GDP on healthcare, and especially public healthcare. Okay, so not any healthcare. You know? So that is the first goal which everybody strives. The government of India is committed to having 2.5% of its GDP spent on public healthcare. Okay, not healthcare from any reason. But if you look at the statistics which we have in front of us, so for example, in the year 2017-2018, you know, the total expenditure, combined expenditure from all sources was 3.1% of the GDP. Okay, so government can say, look, we spent 2.5, we promised, we can have done to 3.31. But then you have to analyze it that of this amount, okay, of the GDP, what the government spending, both at, when we say government, we include the state government, the federal government, the central government, and the local governments, was only 1.35. So means more than double was going either in the forms of insurance covers or out of pocket or other people loans which take, etc. So people are like almost like spending a lot more, and the government's expenditure remains abysmally low. Same year in 2018, 2019, and this is just before the COVID started. Yeah. So it was 3.16% of the GDP, whereas the government was only spending 1.28%. And during 2019, 2020, when the COVID was around and just started, the government spent 3.27% of its, I mean, overall, not the government, I'm saying. The overall people spent 3.2% or from all sources of the health expenditure. However, the government expenditure was only 1.35%. So that means is that it is way short of the 2.5% of the public health expenditure which government promises. Having said that, if that is the government's commitment of 2.5, now we also see that there is the government needs to spend more, but where should it spend? So Indian government, let's put them, I mean, kind of the good thing they have done in the past several, more than a decade or thing is that to set up the National Health Mission, you know, which was earlier called as the National Rural Health Mission, but now it encompasses the urban areas as well. So having said that, the greatest shift we have seen is, for example, in institutional deliveries. Okay, so that area has been strengthened. More and more children are being born in institutional deliveries. So we see it, the impact is on the infant mortality is going down. Okay. Similarly, we see that even because of the whole thing of family planning and providing maternal and child health care, there is an improvement. But however, at that same point of time, so therefore, our fertility rates are also going down as per the latest surveys. So there is a gain which we have made. You know? But at the same time, the nature of disease is also shifting because people are now staying live longer. Therefore, the non-communicable diseases have happened. So that is where the next shift needs to happen. However, that might, if we focus on that part of it, we might leave some populations behind. And the government believes in Sabka Saath, Sabka Vikas. The UN has this slogan, leave no one behind. Right? So if we have to encompass that, then we have to ensure that the marginalized populations, like we said, drug users, sex workers, welfare sex women, also have access to healthcare. And if we are talking about their needs, then what are their needs? Their needs are that, for example, for transgender people, gender affirmative care. We have one gender affirmative care center declared in India and AIMS Delhi, and yet it is to be made functional. So what I'm trying to say is that if and transgender people spend from their pocket to access gender affirmative care, and that's not right, because many of them are bullied, they have to leave their education, they are not very well paid. So why is the system leaving them behind? Hmm? This brings us to the main question, is that what should the government do? Where should the government invest? So the government should invest, for example, in mental health. Okay, our expenditures on mental health for marginalized populations like transgender people, like LGBT, like sex workers. Okay, mental health of business, unheard of. Okay, we don't spend so much over there. So that's one area. Second thing is that any affirmation care, especially for transgender people, is critical, so that they don't spend out of pocket, and they're already poor. So, for example, government has uh, decided that they will issue Ayushman Bharat Plus cards so that transgender people who want to avail of gender affirmative care can use that card. I think that till 2 months back, not even a single card had been issued. Okay, so not even a single person. So I'm saying is this is where the government needs to, so government has shown a commitment, but now the government needs to spend. You know? So committing and spending are two different things. So we government, what I see is that Indian government commits, but the problem lies in expenditure, and there are ways to increase that expenditure.
That's true. So basically, allocating a substantial budget for healthcare initiatives is crucial for what you're saying is it is crucial for equitable access.
So
Um,
having allocating is one thing, but
mhm,
ensuring its utilization is the other thing. So there are two parts we have to deal with. Okay, so
mhm.
not only should we allocate, but we should spend. Okay, now what are the
Yeah.
barriers to expenditure? The
Mhm.
barriers to expenditure we have to identify. So some of the barriers to expenditure is not is like basically the government's policies, okay, of procurement, etc. Can they be changed differently? Similarly, that filling positions in government, for example, for doctors, nurses, okay, can that be changed? Can there be centers for excellence for, like, for example, uh, surgeons, medical doctors, endocrinologists, who can then cater and down to, for example, to transgender people's healthcare. So it has to be like they have to recruit people. Okay, so they have to maybe increase positions in such areas. Okay, for example, is our government willing to increase the outreach of oral substitution therapies? We know oral substitution therapies dramatically improve the health of drug users because they prevent them from injecting and doing other forms of drugs. So harmful methods of drugs. So seeing it as just merely a medical problem and expanding the oral substitution therapies, I think the only government of India which has really, the state government which is contributing from its pockets is Punjab. But other state governments have not went into. They're still dependent on the central government. What I'm saying is, whichever the government might be, whether it is central government or state government or local government, we need to fight, for example, the drug menace more from the perspective of working on the mental health aspects of drug use, and hence, ensuring, for example, one of the solutions is to scale up the oral substitution therapy. So those are the areas where the government needs to invest in for sex workers. I mean, like, for example, what is that needs is basically sensitization, okay, of across. So what can be done for that? Like, for example, Alliance does a very project in Bihar and Madhya Pradesh on orienting the National Health Mission, ASHA workers and ANMs on the issues of health, female sex workers, so that they can incorporate and ensure that, for example, the reproductive health supplies are ensured to female sex workers. So this is the way, we have to look at across the areas which will are being left by. For example, what is can be done to increase the number of doctors, nurses, etc., at the prison, at the sub jail level. Okay, so that is another gray area. So we know that it is a problem to get people out of in facilities, where they're incarcerated. But can the healthcare come to them? In what form and shape? What can be invested in that? So I think those are the discussions that need to take place.
So, considering the global significance of healthcare, what recommendation? I think you have already given your suggestions and recommendations, but still, what recommendations or requests related to healthcare accessibility that you'd like to address to the G20 authority?
So, the G20, I mean, we are talking India specific, but the issues of healthcare are across. So, for example, what is the status of healthcare for prisoners in US? Okay, let's call for that. Okay, so they have an issue. Excess I mean, the number of deaths due to overdose of drugs in US is very high. So what has the government done to address that in their public health system? I can go on and on from every country. And I think there are some issues which pertain to mere simpler things of decriminalizing a particular act or behavior, as in the case of drug use. And I think all governments should act. It is not just Indian government. There are very few governments that have acted on that to decriminalize certain behavior. So Indian government has acted on it, but has kind of stopped of saying, okay, small quantities, we will not do this, but still arrests take place. Police people are not sensitized. So we still face that. Transgender people, a big story across the world in every country. I think the only exception which is not part of G20 is Iran. Right. So unfortunately, where the government does fund sex reassignment surgeries and everything, but again in a very kind of closed environment. So I think is that so this is another area where the G20 as a bloc should be concerned about is that how do we make excess of health? Okay, we talked about oral substitution therapies. We talked about preventing deaths for drug users. We talk about mental health surgeries. We talk about increasing healthcare to prisoners, because it is the drug users, the sex workers, or the clients of sex workers that come to the prisons and come out. So it's just almost a similar population. Similarly, men who have sex with men, gay men, so they have their own needs. And so in some countries, yes, probably the doctors would look out for oral and anal STIs, but in some places still they don't. They have to tell the doctor about it. I think one of the issues which comes foremost is where a big investment is needed is in screening and treatment of cervical cancers and anorectal cancers, which are common in cervical cancers in female sex workers and women living with HIV. And on the other hand, anorectal cancers are now becoming predominant in the men who have sex with men and transgender, okay, especially male.
Hi everyone. Apologies for the disruption caused by our poor internet connection. However, we are back and are ready to continue our conversation with Rajiv sir. So,
please don't call me sir. I mean, like, so we were discussing the recommendations for the G20, correct, and for the countries. So,
yes,
yeah. So I think is firstly is that. I mean, of course, the G20 must at some point, I mean, has to give priority to the public health expenditure, especially in India going to 2.5, and some countries have set the goal for 3% of the GDP. Expenditure, we're not talking about budget allocation. So that is very clear. And when we talk about this 2.5 or 3%, we're talking about on public funding, not coming from the private sector or insurance or people taking loans. So that is very clear. How to make it accessible, the healthcare accessible, there's a huge scope. Okay. And as I said, that there is I was giving examples of what could be done. So one is to invest in health infrastructure. For example, mental health services needed to be expanded. The number of psychiatrists to the population is low. The number of qualified psychologists to the mental health services requirement is low. Okay. Uh, then we don't have a system of continuing medical education for psychologists or counselors, etc. So on a regular basis, that needs to be improved. Uh, Number three, destigmatization of certain behaviors, whether it is even mental health has a stigma attached to it, has to be done. Okay, so that's another area of investment. The third area of investment is ensuring that the infrastructure needs to expand for certain populations. And there I gave examples of how can health services be taken down to the lowest of the closed settings, whether it is a prison, a central prison, or a sub jail, or like a juvenile home, whatever. So it's like there are several closed settings. The, and there's a huge way to scope to invest in healthcare over there. Fifth is that can make services of health services be made inclusive for example, for drug users. So can we expand oral substitution therapy? Can we expand mental health services for drug users? Because they require a special kind of attention. I'm not talking about merely putting them into rehab homes, correct? So on OPD basis, also you can do a lot of stuff. Third is that there needs to be a great expansion of screening for non-communicable diseases, especially cervical cancer and anorectal cancer for female sex worker, transgender men, and men with sex women, as the case may be. The cancer will be different, correct? But the screening should be DNA based, not just swab based. So there is a C, and it's not very costly. It just requires a shift from the perspective of thinking. Similarly, for HIV prevention, for example, just a small one. So Global Fund recognizes that there are certain medical countermeasures, for example, for PrEP. Okay, so this is a tablet which you can take a day to prevent yourself from getting HIV. Can that be made accessible using to ensure that the coverage goes high? Okay. So, uh, so there are other kind of several places. I talk about gender affirmative care. Institutions like AIMS, can they start providing gender affirmative care for transgender people? You know, that requires an investment. Investment not only in terms of the infrastructure, which is required, but also in terms of training the doctors and delivery of those services. And they need to be made as when scaled up as possible. So, so similarly, we talk about like adolescent and adolescent girls and young women. So, can we make services for family planning accessible to them? So, SRH services. Okay, and SRH services which are non-judgmental. Yeah, so we need to make them scaled up and accessible. So, and one of the things which kind of currently, in terms of SRH services, is a barrier in some countries, especially India, is the age of consent, for example, 18. Okay, so person has to, I mean, no teenager in India today will, at the age of 15, will want to take his or her parents, okay, or 16. So can the age of consent be slightly lower down to 16 maybe? Okay, so that people can freely access. Can you have, during the afternoons, uh, so there has been experiments done for adolescent clinics during afternoon when the children finish their or young people finish their schools and colleges and can go, but it has not been expanded. So there are several measures which could be done. I mean, the list is like, we can go on and on and on. But the whole thing is that the government needs to start talking to the community, start talking to young people, start talking to transgender people as to what their needs are. Some of the needs are very vague and established as a matter of fact. The science is established. So it is easy way to pick it up and go ahead. For example, I keep on saying about, let's say, for oral substitution therapies. So like that, I think there is a lot can be done, and which can then contribute to better health facility through the public health system, and which means is that the out-of-pocket expenditure of whether it is transgender person or adolescent girl or things, so that will go less. And that is what we want to achieve. Correct? We don't want people to start spending out of pocket. That's not a right to life. So, and if last but not the least, I think uh, this is my personal view that right to health for a country like India should be made a fundamental right. So, like we have right to speech, we have right to education. So, right to health should be made a fundamental right in India at least.
Thank you, sir. Thank you for sharing your invaluable insights and expertise on healthcare accessibility challenges and solutions. Um, I'll say again that your dedication to improving healthcare access for marginalized communities is truly inspiring. And to our audience, thank you for joining us today. Let's continue the conversation and work together towards a future where healthcare is accessible to all, regardless of their background or circumstances. Do we have a face? Okay, we have questions, sir.
Okay, I'm
Facebook,
waiting. Sure, I'll
Facebook.
take questions. No problem. I'll take
Yes.
questions. We
So
have time, yeah, so we can take questions.
yes, we will answer your questions. Okay, so let's see what are the questions. So Keto has asked that aligning to SDG Goal 3 these days, I don't see any programs. So basically, is there any, Amrita, is there any questions that you see? Please read that. Okay, health for all is not only for the governments, but also for big companies like the HIV/AIDS Alliance. New trends of drug use resulting in HIV, um, H, HIV/AIDS Alliance. New trend of drug use resulting in HIV transmission is being reported among many other things. Has the organization planned anything in this present global fund cycle on these lines? So, would you like to take this question?
Sure. So we know that patterns of drug use keep changing, and they change as so. There are some drugs which come new, some become old, some remain the same, and it is also depends. So I'm not going to concentrate on global fund. I'll come to that after a second. So first thing is that is HIV India Alliance or Alliance India responsive? Yes. Okay. We have been working on the issue of chemsex. We have been working on the issue of sexualized substance use, documenting that how stimulants, used by younger generations are leading to a higher transmission. Okay, so that is what we are documented. Harm reduction needs to now stretch much beyond drug use, the traditional injecting drug use. It has to focus even on recreational drug use. That is one. Have we incorporated anything in the global fund bid? So for that's for me very hard to answer because the priorities are set by the country coordination mechanism (CCM) and by the global fund. So I can see that the global fund is very keen. CCM is taking these very hard calls on what to prioritize, what to not. But I think there is always a window for the communities to influence. So what has changed in this cycle is that uh, there is a prioritization form which is mandatory. Earlier it was not mandatory. So the community can put forth its prioritization, okay, of the issues which they want to see. So Alliance India supported a lot of community meetings where people participated and they listed their participation, they listed their prioritization. And those priorities were sent to Global Fund and to they have been submitted along with the application. I'm not fully aware where what everybody. I think there's some portion in the form of one-stop centers, but I'm not sure because I'm not an expert on that as to how that will pan out. But from the perspective that I'm sure the Global Fund TRP will take a harder look at that issue. I personally feel that harm reduction, the patterns of drug use need far greater attention than what they're getting now. Within that, I personally have feel, and then we have tried to do projects with female drug users, especially female injecting drug users, which are the most neglected in the whole spectrum of the populations at risk. And I personally feel that the time has come where uh, the government should not be saying that we don't have enough numbers. Every life is important. And even if it is small number, then we have substantial numbers in, like, for example, in Nagaland, in Manipur, in Punjab, now even emerging in some other states. So there is a case to invest in harm reduction, especially for female drug users.
That's true. So we have one more question. So is there a global platform to exchange best practices in the areas outlined? So this is from Anubhuti.
So there is usually they are not singular platform, there are multiple platforms. And the platforms can exist in webinars which are organized time to time by donors. I know, like, USAID and Global Fund are the two most regular organizers of best practices, and UNAIDS at times. Uh, the other platform, of course, are conferences and seminars. For example, the International AIDS Conference, which happens, but there are also now conferences on TB, on malaria, and on hepatitis. So I neglect, I mean, I think I forgot to mention hepatitis in my earlier. So that's another area, especially with that cuts across several populations. It cuts across, for example, men who have sex syndrome, transgender, and drug users. Okay, which drug users being the most impacted. So, and it is the treatment is much costlier. So, as I said, that this is another area, and linked to that, the one area which I think I skipped because of the technical disruption is vaccines. So, so promoting vaccines like say, hepatitis B and C, or any other vaccine which is available, for example, for HPV amongst young girls and boys. Okay, I know there is a religious sensitivity to that issue, but it helps save lives. So, so promotion of vaccines is very critical in these days, and there are best practices which are exchanged time to time. So my answer would be for Anubhuti is that register yourself on various platforms, and I see almost every week at least one webinar happening, and sometimes I join in, and there is a wealth of information that is available.
So Amrita also wants to know that do you have any recommendations, suggestions on universal healthcare coverage?
So, as I said, universal healthcare coverage. So there are several views about it. One view says is that it's government responsibility to ensure that everybody has access to health, and I agree with that. Okay, and that is where I personally feel is that uh, so it should be, when we see universal health coverage, it is about everything. All kinds of health issues should be dealt with. Uh, right now, we are way beyond that. So people are looking at models of universal health coverage in a total market approach. So even if we are talking about private sector engagement in achieving universal health coverage, I think there are two, three things that have to be kept in mind. One, that services which we provide should be of ethical nature. Two, it should be cost effective. Three, it should not lead to any out-of-pocket expenditure and burden. So in that sense, yes, insurance companies, but health insurance is a big sector. It will continue. But at the same time, looking at the amount of refusal which happens from the insurance companies about various expenditures or the exclusions they do. For example, they do not cover diabetes for 4 years, 5 years. There are health insurance companies in India which refuse to give policies and they don't give it in writing. So they have a very discriminatory attitude towards people who are living with diabetes or have cardiovascular diseases. So I think it is the responsibility of regulators like IRDA or whichever might be the name in their country, or the Ministry of Health, to ensure that there are no exclusions. There is cannot be an exclusion to healthcare. For example, in India, the insurance companies do not provide health insurance to citizens above 70 years. Why? Are citizens above 70 years not entitled to healthcare? Okay, even if they can want to pay for it, or why should they pay an extra premium for it? So I think it is a serious issue, and I feel universal health coverage, the game of the rules have to be amended to make private sector accountable, and it is not merely the public sector. So the private sector cannot run away from its responsibility to provide equitable health access, okay, in the form of, even if it's a paid service, but in the form of cost-effective and non-discriminatory.
Um, yes, thank you, sir. I don't see any more questions now. So I think, yes. So should we wrap up?
Yeah, we could.
Okay. Thank you, sir, for your insightful expertise on accessibility challenges and solutions. And to our audience, thank you for joining us today. Let's continue the conversation and work together towards a future where healthcare is accessible to all, regardless of their background or circumstances. Stay tuned for more updates and discussions from Alliance India. Until next time, take care. Thank you.
Bye. Take care.